Welcome, everybody, to the Neurocritical Care podcast. This is the Perspective series. I'm your host, Nick Morris from the University of Maryland Shock Trauma Hospital. And today I have the honor of interviewing Dr. Tommy T. Thomas. Um, Dr. Thomas is a neurointensivist and associate professor at the Emory University School of Medicine. He completed an MD, PhD from University of Alabama, Birmingham, followed by a medicine internship there. He then went on to neurology residency and neurocritical care fellowship at Partners in Boston. He has been at Emory University in Atlanta ever since. And I've had the real pleasure of working with Tommy through the Inclusion and Neurocritical Care Committee at NCS. And it's been really nice to get to meet him. And I wanted to invite him on the podcast and talk a little bit about his perspectives on neurocritical care and some of the work that he's done through Inc. in the DEI space and how we can do better. So Tommy, welcome to the podcast.
Thank you so much for having me.
Great. Maybe for the listeners, it would be helpful if you could start by telling us a little bit about your path into neurocritical care, what got you excited about it, how'd you find yourself here now many years later in Atlanta?
Excellent. So, well, my path was fairly direct. I mean, as I was finishing up residency, I started looking around for fellowships, started talking to people, and I was really torn between neurocritical care and, believe it or not, neuro-oncology. I like the idea of kind of patients with advanced disease and illness and the opportunity to help those patients. And I talked with a number of people, including Galen Henderson, and I also talked to friends and family who kind of knew my personality. And one friend provided me with the most sage advice, which one of them scares you more? And I was like, oh, definitely neurocritical care. Like it's a bit insane. It's kind of odd sometimes. And she said, well, you should do that one. And so here I am. But I always found the disease path and the pathophysiology fascinating, and the opportunity to really bring medicine back into my neurological practice and become an intensivist was exciting, and it's been even more rewarding than I imagined that it would be.
Yeah, fantastic. I also thought about neuro-oncology. I think it makes a lot of sense to me. A lot of medicine in neuro-oncology, right?
Right.
So I think there are some clear overlaps. We end up taking care of a lot of tumor patients in the ICU, at least in the post-op setting. So that makes total sense to me. Can you take us back, I guess? So as you're a resident in neurology, you're looking around and trying to make the decision between neuro-oncology and neurocritical care. And you mentioned Galen Henderson, and Galen's someone that I worked with and actually is on the Inc. committee with us. I just as you were looking to make this decision and you talked to Galen, what were you seeing in people like Galen that inspired you to go into neurocritical care? Was it just the content of the different specialties, or was it the people involved as well that kind of drove you towards the decision?
No, certainly the people and the personalities within neurocritical care that I found to be very similar to mine. Of course, there were differences, but they were all very similar to mine. There was an intensity, a desire for kind of procedural knowledge, but there was also this kind of I don't want to say go-getter attitude, but there was definitely a I want to do something and see what happens pretty quickly after that. And the neurocritical care offers that feedback where a lot of other paths don't, especially neuro-oncology, where there's kind of a longer lag phase and kind of reaping the rewards of your interventions. Neuro-oncology also fit into my research at the time, but there were also, I saw neurocritical care as kind of an unbeaten path. There was a lot of opportunities for a lot of different things and a lot of advancements within neurocritical care, and so that really guided me. And Galen always has a spirit that when he talked to me about kind of the professional life within neurocritical care, how he integrates it into his personal life, it really seemed like the career for me at the time.
Could you talk a little bit more about that? This is, I think, something people struggle with a lot, is how do you integrate the professional life of neurocritical care into a personal life?
Well, at the time, Galen talked about it being kind of on and then off, and you really don't. It's not like the clinic patients where you're following them all of the time. There's an intensity to it, but there's a time for recovery that seems a bit greater than some of the other fields. However, the intensity is also a bit higher. But he talked about kind of integrating it in, specifically from the standpoint of time, because there were larger blocks of times to do other things. And he also talked about the way that neurocritical care is done, because it's a 24/7 field. There isn't really a start or a finish. It's just kind of when you start and when you finish. And so he really talked about the flexibility within the field as to kind of how you did things, how you treated patients, when you rounded, how you rounded, whether you rounded kind of a multitude of different times for short periods, one long period. And so he really talked about kind of molding the career to fit my personality and my interests, both inside medicine and outside.
Great. And it sounds like you have no regrets with the decision. What over the years have you found that you really liked most about the field? What's resonated with you? Has that changed over time, or has it stayed steady?
I think as the field has evolved, the same types of things have generally kind of brought me joy and resonated with me. The opportunities to really kind of help people have really significantly increased. I mean, even if we look at things like thrombectomy for stroke and the advances in that, we've really been kind of able to see an evolution within neurology and critical care as to how we care for stroke patients, how we care for subarachnoid patients, and how those patient outcomes have improved. We've also seen kind of changes in the way the work has done with regard to predictive analytics and bringing other types of things into kind of the pursuit of neurocritical care. And so I think the field is advancing more rapidly than I could have anticipated. And I enjoy that. I enjoy that there's a novel aspect to it that kind of keeps coming up and is reiterated over time.
And is there anything in particular that you're finding really exciting right now? Some area of the field that you think is really about to take off or explode?
Oh, I think there's so many areas. I think with regard to things like consciousness, Jan Clausen's work and Brian Edlow's work on states of consciousness and kind of surveillance are really going to change things like brain death within the field. I think all of the neurointerventional work and the recent kind of advances in who gets thrombectomies, who gets neurointerventional care, are really going to change not only kind of the patient pool that we take care of, but how we take care of them, and hopefully will offer some advancements and improvements in outcomes from that. And so I'm excited to see kind of all of these new technologies coming in. We're still on the cusp of AI and getting predictive analytics in there. And I think rather than kind of taking over any roles, those analytics and AI will help us to do our jobs better, faster, more efficiently, and kind of again integrate our lives both inside and outside of medicine more efficiently.
Wouldn't that be nice? What are some of the frustrations you've had in the field? Some of the challenges you faced?
Oh, the frustrations are numerous as well, unfortunately. I think a lot of them, if I were to kind of do a root cause analysis of my frustrations with the field, most of them start to stem with kind of the corporatization of medicine, as we've seen over time. The numbers of intensivists and APPs and people around us hasn't really shifted significantly. The numbers of people within the corporate structure of medicine have increased dramatically. The number of kind of middle managers and the amount of effort it takes to get small changes implemented is really, really kind of frustrating. It really kind of stagnates change. And I think we as physicians, I think part of our personality is to accept things and to take part of our payment in the pride that we have done good work. And I think with the corporatization of medicine, we are going to have to kind of push things along and take a more kind of leadership role in both how things change and kind of being more actively involved in the evolution of medicine before it's kind of taken out of our hands and before we become kind of shop floor workers, which I don't particularly care to be.
No, me neither. I joke with colleagues that here we have these kind of position tags that go on your ID. And I think as you walk down the hall in our hospital, it's like every third person says either manager or director. And I imagine like what that's like for someone who doesn't work in the hospital, who's like, who are all these people managing? Because it seems like the whole place is full of managers. Just speaking to this corporatization. This is a little bit off the cuff, but let's go there. So you mentioned floor shop workers. We don't want to be that. One thing that we've seen happening in residency and training programs recently is unionization. There's a reason why unions form among floor shop workers to protect their rights. I'm wondering, as this generation of residents or fellows who are now unionizing kind of graduates to early faculty, whether there might be a push to see some unionization at the physician level, or at least some way for us to band together to have more of a voice in corporate American medicine. And what are your thoughts on that? And is that something that we should be doing, or?
Well, I can't say should or shouldn't, but I can say that I mean we're both a part of Inc. and we both talk about representation a lot. And I think if we take this away from that lens of necessarily diversity for a moment, I think if we look at what happens in representation, then representation really kind of shows you what you can be, but it also gives you a voice. It also provides some sense of protection. And frankly, I mean, we've been doing this in a similar fashion with some small changes, but in a pretty similar fashion as when Osler was doing it. And that's a long time to be doing things the same way. And usually as time goes along, there becomes a little bit of creep, especially as you age in the career. And it becomes a little harder to see some of the eccentricities and idiosyncrasies that need to be corrected. And I think with youth, there comes also a vitality for change and an intolerance of things that seem unjust or injustices. And so whether it be a union or just kind of louder voices, I do think that there is a real need for people to speak up and to be heard and to make some noise and to make changes within the way medicine is practiced today.
I completely agree. And maybe we can use this as a segue into talking about some of our work in Inc. together. I'm struck by this quote. I read How to Be an Anti-Racist not too long ago by Ibram Kendi, and he said something I found very powerful, which is that in insidious forms of racism, people are often blind to but they hold a pivotal role in upholding racism, and people don't see it because these attitudes are often so deeply ingrained that it takes the ability to be deeply self-critical to examine and challenge these attitudes. I think there's a lot of corollaries to this in medicine. We have these deeply ingrained parts of our culture that we're often blind to. What are the insidious forms of if not just racism but unjustness that are happening in the hospital that you see, and who do we need to give a voice to?
Well, I think we often tell ourselves a single story about existence, about people that we meet, about situations that we find ourselves in. From an evolutionary standpoint, this is how we survive so long as a species. We make quick decisions and we stick by those decisions, but in doing so, we really kind of tell only one side of the story. We only really kind of attend to one perspective. And in so doing, we miss out on all of the possible other multitudes of stories and perspectives and truths that can simultaneously exist. And when we talk about kind of the construct and construction of society today, it was really based on kind of injustice and injustice. It was really based on unpaid labor and building a foundation on the backs of that unpaid labor. Now, when we talk about kind of moving forward to that from that and making changes, if we don't take that into account, then it's hard to really kind of make changes because we're skipping over so many steps. And when we talk about kind of getting a seat at the table, we don't really look at one who made the table, who constructed this table, who was supposed to sit at this table, and why we would want to have a seat at the same table that has ignored and kind of maligned us for so many years. And so it really, in order to kind of build constructs in justice, we really have to kind of tear down some things. And I'm not sure that people are really ready to tear down things so much as they just want to kind of make a gentle diversion. And I don't necessarily think that's enough to make substantial change. Certainly it will make incremental and glacial change, but in order to make substantial change, there has to be some sort of reckoning about the past and how it has created the present in order to move forward.
That's really powerful. Have you seen changes in your career that you would consider significant in this regard?
Well, I think as time has gone along, I have become more comfortable in who I am, and not having to necessarily demonstrate or prove who I am in given settings. And that's a double-edged sword because when I walk into a room, there's generally an air of lack of familiarity. Sure, they know I'm a doctor. Sure, they know I'm Black, but they don't necessarily know any other parts of my story. They don't necessarily know kind of how my foundation was built and what that means for me to be who I am now and walk into this space. And so, as a kind of a hidden unicorn within the space, the assumption is that I'm the same as everyone else. I'm a horse, and it's not true, and it skips a lot of steps and makes a lot of assumptions that if you look at those steps and assumptions, they really create kind of a different being than anyone else, and everyone there is an individual to their own degree, with their own thoughts and beings, but they really kind of don't look at kind of my career path, kind of how that has gone, the things people have said to me, both good and bad, the little things like when we talk about representation, and no, I don't see a lot of Black doctors. I don't see a lot of black men in the medical profession, but I do hear a lot about all of the diseases that disproportionately affect the Black community and the Hispanic community, and the list goes on and on. I do hear about the inequities that aren't even corrected with socioeconomic status when we look at maternal mortality. And so these are the things that I hear with different ears, because this is the community that I belong to. This is the community that I'm from, and so these things affect me more viscerally than they do on the surface. And that's not to say that someone can't understand them if they can't feel them, but they sometimes need to step outside of themselves in order to kind of make that happen and tear down the constructs that have been there and placed there before.
Got it. And so, it strikes me as one solution to this. Obviously, there's no one solution to this problem, but one solution would be, to increase the number of Black men in neurocritical care, increase the number of Black women, increase the number of everything in neurocritical care. So we have a more diverse workforce that better represents the communities that we serve and really can interpret those patients and their illnesses through that lens. We just finished our, we have match day actually is coming up on Thursday, I believe. We just submitted our list. The group of applicants out there is not overly diverse. I think it's something we look at as a major deciding factor in our program, is we'd like to diversify the trainees that come through our program. And yet that's been a challenge for us because the applicant pool is not overly diverse. How do we, you hear always about the kind of growing the pipeline, or how do we do this in neurocritical care? And probably it has to go back before neurocritical care to neurology residency and even to just getting people into medicine to start with. But when we put all of this in context with the recent court decisions on affirmative action, I'm seeing that potentially things are going to get worse and not better. What are your thoughts?
Well, I think my thoughts really kind of go back. I mean, I've posed this question to myself over and over again, and I don't necessarily have an answer. But I think a lot of it goes back to kind of assessing those foundations upon which all of this is built. Right now, what we're trying to do is we're trying to build diversity within a field that was frankly designed for kind of historically rich people, particularly rich white people. And if we suddenly shift our lens and say, well, we want to make this diverse, well, is this the most socioeconomically uplifting field for someone to think about joining? Is this the most supportive field for someone to join and feel supported in who they are as an individual, or is there kind of a cult of personality and a zeitgeist that exists within this field? I think there is a comfort with bringing people into the field as it is, but there's not a comfort with changing the field to accommodate differences in personality, gender, race. I don't think the field is ready to make any type of shift towards that, and that shift is necessary. And that shift doesn't mean that we accept subpar applicants. That shift doesn't mean that we don't have excellence. If anything, changing both the people that are thinking and the different types of thought that are available within the field, it makes things better. I think there's always a desire within medicine, especially for consistency and maintenance. And I think last year there was a question during one of the sessions. And it was, so how do we encourage diversity and still maintain excellence? And I think
that's such a loaded question.
Right? I think that's a loaded and dangerous question. Yes. because one, are we maintaining excellence, or are we maintaining a status quo? And
it seems to assume that if you add diversity, that excellence is in question, right?
Exactly.
That's the underlying assumption.
So it makes a counterfactual argument that diversity somehow limits excellence. And I think that is one of the things that's subversive. Going back to that quote, that's one of the things that people don't know that they have in their minds. People that don't know that they carry this with them. However, I think this colors and jades the types of thoughts that people have about the table, bringing people to the table, encouraging leadership that looks different, that acts different, that sounds different. And so I think when we ask about kind of how do we diversify medicine, I think we have to ask ourselves, well, who is this currently good for, and who can currently do this in the way that it is right now, and is that the way that it should maintain? I mean, if you're a poor kid from rural Alabama, I mean, I was a poor kid from rural Alabama, is this the best choice to make? Or is the cost too great? Does it ultimately become a Pyrrhic victory within your life? And so I don't know. I don't know what the answer is, but I think there are lots of questions that we skip over in pursuit of the answer that we have to sit and uncomfortably address before we can kind of talk about solutions.
Yeah, I remember there was a survey of recently matched neurology residents that came out several years ago, and it was basically asking their reasons for going into neurology, and why did they choose it, or why did, what factored into that decision, what did not. And one of the things that was at the very bottom of the list was pretty much no one went into neurology for the financial perks, which is well-informed thought, but it's very privileged, right? And the discussion was sort of centered around, how great that people go into neurology mostly for this pure academic love of neuroscience and to understand sort of the essence of humanity. And yet it just kept striking me as, wow, this is really a privileged space to look at this from. And I'll admit, my story is I'm the son of two physicians, white male. I went in for the same reasons as that survey kind of highlighted. And yet, I know people, plenty of people that I went to med school with who were loaded down with debt, and they were really making practical decisions in part in choosing their specialty. And I don't think that that's a bad thing.
Right. I mean, at the end of the day, I mean, there is a quest for survival and thriving. And sure, medicine still has a allure. It still garners a respect from certain members of the community. However, pay and passion and having a prestige career is a trap, and it eliminates a certain pool of people who can't afford to live their lives that way, who can't afford to who can't lift their families up out of poverty, who can't move themselves within the stratosphere of survival. And if we look around at the socioeconomics of medicine, if we look around at who becomes doctors and why, it's hard to compare, because most of those people are from the top quartile, if not top 10% of if not salaries, net worth. And if you try to make this offer as kind of an appealing career choice to someone from a lower socioeconomic status, the amount of things that they'll have to sacrifice in terms of unpaid positions, kind of poorly paid positions, compared to their peers, it's hard to make the case that this is a viable option for them.
And can we take this opportunity then to talk about, for those that do, we hear about the minority tax, right? This unfair burden of placing all of this hard work on those people that represent those groups that have made it through. And how have you dealt with that in your career? Are you still, is it still a struggle continuously? And how would you advise young, faculty to manage that?
Oh, I mean, it's a continuous struggle. It's a privilege and an honor and a struggle yet and still. I feel like in all advocacy work there becomes a bit of self-sacrifice, and part of that self-sacrifice aligns with this kind of black tax, minority tax. Um, a lot of the times when you're sitting in a room and you're the only one, you're also the only one that has the potential to answer certain questions, and you're also the only one that people look to, and so you end up in a lot of things that are steered around kind of who you are. You end up on a lot of committees because they need your voice, and the career needs your voice, but it doesn't come with the prestige that it should. Their promotions aren't based on it. That it's not recognized as the time sink and effort and important effort that it is. And so it becomes more of a tax than it is an opportunity to help. And so that's a problem. I think it deserves and warrants more recognition and more understanding of it. And I think it is something that is so prevalent within all careers, but especially within medicine, because now, as time has gone along, for great reason, there is more attention to the problems, but there are not a lot of solutions. And I think more people are needed to be at this table, but they need recognition for coming to the table and offering what is kind of oftentimes trying and traumatic stories about kind of what has happened to them in their past and how to prevent this from happening in the future. As far as kind of the next generation, you really do have to look within yourself and say, can I afford this? Can my psyche afford this? Can my family afford this? Can my life afford this tax? Is this something I can do? And there's no right or wrong answer. I think it comes down to a really a personal choice. But you have to know that this at times is going to be requested, and you also have to know that no is a power word. You have to be able to say no, and no takes you a long way.
Can you talk a little bit more about what you just said? You mentioned that the minority tax, it plays a role on your psyche, and I think this is probably overlooked, that maybe some well-meaning people think, oh, I'm giving you this great opportunity, this is probably something you're going to be really excited about. What is the kind of the cost to the psyche involved in doing this work?
Well, I think it starts well before this starts to occur professionally. I think it starts to occur with the statements just in medical school about kind of the social determinants of medicine, which they're just starting to call it. But I think when you start to talk about kind of who's affected by these diseases, and you just say things like, oh, it's disproportionately this, or it's this. You don't even say disproportionately, you say Black people are more affected by this disease, and that's it. You keep going. You don't talk about why. You don't talk about social determinants of health. You just say, oh, this is a Black disease, this is a woman's disease, this is an X disease. And I think that starts to build kind of within your core, and you don't know it. And I think that's part of what's underlooked throughout this whole experience, is that part of what racism and social injustice does is it makes you look at your own group the same way that everyone else does. And so it starts to build within you. And then suddenly you're in a position, and you already had this. You leaped over all of these hurdles that have been created by who you are through no fault of your own. And then you get to a position, and you're asked to do these things. You're asked to be on these committees. But these committees don't oftentimes don't have a power in the ethos of wherever they are in the structure of the organization. They sometimes are a checkbox, and they oftentimes don't offer an opportunity for advocacy. And they ask you to speak for an entire group, assuming kind of this group is a monolith. Whereas there are so many differences and unique eccentricities within the group that there's no possible way that you can speak for everyone. And they don't allow you to be an advocate. And what I mean by being an advocate is rather than speaking for someone, they don't allow you to bring other people there to speak for themselves. They don't allow you to dismantle the table that has been created. So it wears on you, because not only are you doing this, it seems like you're on a treadmill. It seems like you're just kind of running in place, and you're sweating and you're huffing and puffing, but you aren't really going anywhere. And so you have to decide whether incremental glacial change is something that you find rewarding, is something that is not going to kind of eat away at your soul and your psyche, and contribute to kind of your own breakdown and stress. We don't really kind of attend to that enough, kind of how we feel, basically.
Yeah, and it strikes me as something you said in the beginning of the interview, which is one of the things you liked about neurocritical care, is you like to make a change and then see the response in a fairly acute way, unlike neuro-oncology. And that personality is the exact opposite of what you just described, of this treadmill of hoping for glacial change trajectories. It's a real maybe challenge in our field that's somehow perhaps more challenging in our field than others.
Oh, absolutely. I mean, we are not a field that's designed to tell our own stories and to talk about our own moral injury and burnout, and kind of foster compassion among each other. I mean, we do a lot about and talk a lot about kind of fostering compassion and healing of patients, but we don't look within our own career and kind of foster compassion and promote healing of each other within the career. And I think that is kind of a siloed manner of kind of ethical decision making that is really problematic.
Yeah. How can we be good allies?
I think we talked about this a few moments ago, but I think being good allies means, rather than telling other people's stories only, I think you really have to pull those people to the table to tell their own stories. I look at I think two people that were pivotal within the society for me. One above me, one below me, or not below and above, but one was there before and one came after. But Christine O'Phelan really kind of pulled me into Wink when as kind of as the only male member, and the only kind of black. I was a black guy, and she said, "Hey, you should join this group." I joined, and I think that was instrumental in being able to kind of tell my story and other people to tell their story, and it evolved into Ink. I think Amy Eisen, who came after me, she was a few years junior to me, but I think she has spoken up for me and underserved people within the society and within leadership, And I think how to be an ally means really kind of bringing people to the table to tell their stories, to telling different stories yourself, and kind of fostering kind of listening to those stories and understanding that there's so many multitudes of simultaneous truths and perspectives in any given moment that kind of color these lived experiences that need to be heard in order for there to be change. And I think allyship really means kind of allowing people to stand on your back and speak for themselves.
For people within NCS or beyond who want to start this journey into being a better ally, are there any resources you recommend or ways to get started?
Well, I think it really starts with listening. I recently have been involved in, and I think it's kind of a new, I think it's kind of a new thing, but it's called narrative medicine. It came out of Columbia, and it's really kind of the practice of mindfulness, and kind of communicating and assessing all of these perspectives and truths that we're speaking about. And it I think you really have to kind of start to learn to closely listen to the stories that people are telling you, and closely observing what's going on around you, and looking for different perspectives than your own, stepping outside of your own silo or spaceship or bubble, and really looking into kind of others' lives and seeing what's missing. Certainly there are all types of resources that will tell you steps in allyship, but I really think that in order to kind of take those in, the first step is to really understand and learn how to listen and be mindful and to be introspective and step outside of yourself. And I think without that, it's hard to subsequently take in all of these steps and become a true ally.
Absolutely. Maybe we'll just wrap up now. There's a few questions we sort of ask everyone who comes on the podcast. There's kind of quick hits, we call them.
Okay.
That was pretty deep and powerful, and these are going to seem perhaps out of place, but we'll.
I like it. I think we need a little levity.
Yeah, we need to bring a little levity to the podcast. It's but this has been really fantastic, and I've learned a lot. What do you do outside of the ICU? What do you do for fun? What are your passions or hobbies?
It's funny. The last time I answered this question, it was eating and drinking, but
Me too.
But I would lie if I would say it's not that. I mean, when I travel to go to certain restaurants, and so I experience culture through food. I like to call it peasant food sometimes, but it's not all kind of Michelin star. I really like to kind of experience kind of what people are eating, how they eat, how they gather together and commune. And so I think that's a big hobby. And I spend a lot of my time in pursuit of that, in pursuit of kind of food and that experience.
Cool. Me too. I just was in Minneapolis with a bunch of another neurointensivists, and we went to this restaurant called Owanmi by the sous chef, and its whole deal is it highlights the food of indigenous people.
Oh
and
yeah.
they have no like post-colonial ingredients, so
Nice.
there's no dairy, right? Because there's no cows, there's no
Right.
beef, there's no pork, there's no chicken, there's no flour, there's no sugar cane. And it was wild and it was delicious. So we had a great time.
I think that's amazing. I also think that lots of people and most people show love through food. And so like if you gain an understanding of kind of people's foods, then you really do get an understanding of kind of how they care for each other. So that's
It was really cool. There is that the pride and enthusiasm from the staff was so infectious. It was like we all kind of walked out with just a huge smile on our faces because of that. So what other specialty would you like to attempt, or would you have, you mentioned oncology, but outside of neurology, maybe completely, what's something you would like to try?
um I think about kind of neurocritical care and neurology within the frame of kind of hardware, software, and I think about kind of neurosurgeons as being kind of the expert hardware kind of technicians, and then neurologists someplace in between, and then psychiatrists to really deal with the software. I kind of like the software. And so if I were to do something else within medicine, it would probably be either psychiatry or anesthesiology, because I find consciousness to be strange from an existential standpoint. And, I don't think any of the work thus far, Emory Brown and lots of people are doing lots of different work on the nature of consciousness. But I would probably move out of medicine if I were really to do something else different. But within medicine, I think those two get the closest to consciousness and existentialism. And so that would probably be what I did.
All right. And what's a specialty that you would not like to do?
Oh, there's most of them. I think this chose me more than I chose it. I couldn't see doing most other things, maybe cardiology, but I think of that heart as a lump of muscle. Neurosurgery, but standing and looking in this tiny little surgical field for hours seems less than appealing. So there most things I think I would sway away from.
Yeah. I remember my first experience in the OR in neurosurgery as like a third-year med student. I was like in heaven for 30 minutes. And then about 9 hours later,
right.
I was ready to go.
Right.
Is there a sound or smell in the ICU that you like?
So this goes along with my alarm fatigue, but I love the cacophony of alarms. It's not the same now as it used to be, because we have become more attuned to alarm fatigue. But walking in and hearing the ventilator alarm, I used to just love that. I felt it made me feel like I was at home, and hearing everything kind of go off asynchronously. Those were the sounds that I really liked.
Yeah, I'm with you on that. If I had a sound machine to put myself to sleep, it would be asynchronous vent alarms.
Exactly.
And is there a sound or smell in the ICU that you just hate?
Oh, there's so many smells that, like, the smell of the ICU is something that I find terribly revolting, and I'm almost ashamed to admit it, but I sometimes the smells are just a little bit too much. But so any smell within the ICU.
And finally, what general advice would you give to a fellow about to graduate?
Be yourself, make your own way within your career. Say no as much as, if not more than, you say yes, and really plot a path out that fits within who you are and the life that you want to lead.
All right. Well, let that be the last word. Tommy Thomas, this has been a real pleasure. This is probably the deepest and most impactful interview we've done, and maybe whoever will do on the NCS podcast.
It's probably too much, but that's fine.
I really enjoyed it, and I think our listeners will too. So thanks so much for your time, and I hope to see you in sweaty Phoenix.
Indeed.